Dear friends, dear urologists from all over the globe, welcome to this UROLUTS educational platform interview with my esteemed colleagues. On behalf of the editorial board, we have Sachin from London, glad that you can join us. We have the fantastic Manuela from Milan, which is also taking part in. And we'd like to discuss with you the best practice recommendation when it comes to assessment of male LUTS according to current guideline recommendations. So Sachin and Manuela are part of the guideline panel when it comes to EAU guidelines. Last year I was involved in the German guideline recommendation. It's interesting to see for all colleagues all around Europe why there are small differences in the management, or what we consider to be the best management, and that's why we are here to discuss with it. So let's start with it, and first question up to you. What would you say should be considered the basic assessment of every patient that presents with lower urinary tract symptoms?
Okay, so Giuseppe, it's not one size fits all, and this is the main thing we should, I don't know if you agree, but it's the main thing we should think about when we counsel our patients and when we assess our patients. So we have a basic assessment which all of us know that is correct. So a good anamnesis of the patients, a good history taken together with post-voided residue or with uroflowmetry, and this is something that we can afford in quite every center. But then we step to other assessments that are more let's say sophisticated, and not everybody can do in their center, not everybody it's allowed to do in other centers, and we have also to think about all the problem of reimbursement of these techniques. So I think with the guidelines we aimed at giving a kind of overview on what is the best type of assessment we can give to our patients, but of course we should think about the different strategies we could have in the different places. So I think also you can confirm this with the German guidelines, because we have in Germany, in Italy, in the UK, I think we have different strategy of assessment which are a bit cultural, a bit connected to the reimbursement type we have. So we should think about it even if we follow the guidelines.
So as you mentioned, uroflowmetry,
yep,
in your opinion, should be considered as basic diagnostic step. How do you see that, Sachin?
Yeah, I completely agree. I mean, I agree with what you say, that we do have to try and individualize things. But I mean, generally, for a man presenting with LUTS, I think we would agree, pretty much across the board, that uroflowmetry, post-void residual tends to be a very basic test. You can kind of do in the outpatient clinic. Most people have access to, and it's a good, it can be a very good, at least indicator of what might be driving the lower urinary tract symptoms, where to direct the treatment. So I think it obviously has limitations, but I think definitely in the initial assessment, basic kind of investigation, I think the uroflowmetry and the post-void residual are definitely useful, and I think that's reflected as well in the guideline.
Okay. That's quite interesting, because in Germany, uroflowmetry was taken out as basic step in the assessment. It's a additional step that can be done if some questions have not been answered. The limitation of uroflowmetry definitely is it cannot differentiate between bladder outlet obstruction and the detrusor underactivity. So this was one main reason why it was taken out. On the other hand, epidemiological data suggested that only 10 to 15% in Europe actually do uroflowmetry. So in Germany, their step to go was actually to include more ultrasound-based techniques. So something which is mentioned in the European guidelines, but considered a basic diagnostic step in Germany, is the measurement of the detrusor wall thickness, as it's a good parameter to suggest bladder outlet obstruction. and in addition to that, intravesical prosthetic protrusion. So when it exceeds 10 millimeters, it's also a good parameter which suggests and indicates a bladder outlet obstruction. So these two have been taken into this whole setup for basic diagnostic assessment. I think it's interesting to see whether in Europe something like that could actually be implemented in the clinical practice. I see it in the UK, definitely a big problem.
Yeah, I think it's a very good point you make, and I think that's one of the differences or difficulties when doing a guideline, an international type guideline, is that you lose, because of the cultural differences that Manuela you mentioned, and the kind of local practices, you kind of lose the ability to make certain recommendations. So, for example, what you mentioned here about the detrusor wall thickness and the IPP, we in the European guideline, in fact, we summarised it under non-invasive tests, urodynamic non-invasive diagnostic tests, based on a review of some of the evidence, which was a while ago now, and we thought, okay, look, maybe there wasn't enough evidence to recommend it generically. In fact, in the UK, it's quite hard. As urologists, we don't often do the ultrasound ourselves.
I see.
So we refer patients to our radiologists, who would then do the ultrasound measurements, the IPP, detrusor wall thickness. And so logistically, it's a bit more difficult, adds another layer of cost. And so it would be hard, unless there's very good evidence that it's better than urodynamics or very effective at helping us direct treatment, then it's a bit harder to make that recommendation, I think. But I agree with you, there's lots of good evidence on it at the moment.
And how's it in Italy? Could you think of measuring IPP?
I think so. We are not doing it now in the clinical routinary practice, but I think we could do, because we urologists, we perform ultrasound, transrectal and transabdominal ultrasound. But the thing is that you should go into depth because of a kind of habit in performing that kind of ultrasound with specific outcomes.
I see.
So if you are not used to measure the thickness of the bladder wall or the intraprostatic protrusion, you will spend more time in doing that examination. So you have to change your way of planning patients. So you have to change actually the assessment of the patients, even in a matter of organization.
Yeah.
So it would be difficult. It can be done, but it would be difficult, especially because we don't know very well, and we said also in the guidelines, the accuracy of these techniques.
Exactly. And I think the hard thing with the diagnostic, everything is compared. It depends what you compare it against.
Yep.
And a lot of the studies compare the non-invasive tools to uroflowmetry, for example, which itself is not the best judge of obstruction.
Yep.
So it's quite hard, as you say, to truly work out how beneficial they are in then guiding treatment and then getting the right outcome.
Okay. So it's interesting to see how many obstacles we have to overcome in each country when we are supposed to do the best management for our patient. But Sachin, you mentioned it's urodynamics.
Yeah.
So what's your point on that? Is that something we should include as a regular diagnostic step in every patient, or do you have concerns when it comes to best practice recommendations for our patients? Is that something we have to do in every patient, or is it still restricted in certain situations?
Actually, what we know now is that there are some studies, recent studies, addressing the fact that it's not necessary to perform urodynamic in every patient. But we also know from our clinical practice that in some patients we need to perform it to be sure on what to do. Actually, there is no answer. It's better to perform it or not in patients with obstruction. But what we know is that there are probably some specific cases in which urodynamic can help in predicting the outcome and in choosing the most suitable treatment for that particular patient.
And what would that be, for example?
For example, when we find patients who have already detrusor overactivity or symptoms, and then we check for detrusor overactivity, which can be caused by obstruction, but also from aging, or in neurogenic patients, of course, or in patients with something that can render the bladder neurogenic, like diabetes mellitus or vascular problems or strokes. So we should adapt our assessment to the patient we have in front of us. And we know from literature, from let's say a small group of patients coming from the upstream trial, that patients with the bladder obstruction index, high bladder obstruction index, and high bladder contraction index, maybe they can benefit of urodynamics in assessing the probability of improving IPSS after surgery, if they have not the detrusor overactivity. So again, the detrusor overactivity is a good parameter to choose what to do or to better inform the patient, because at the end, the selection of the patient is the key.
Absolutely. How do you see the role on urodynamics?
I 100% agree with what you say. I'm glad you mentioned upstream, because that's kind of, at least in this area where there's not a huge amount of evidence for or against urodynamics, at least that gives some information. Actually, the thing I found most interesting about that trial is the sub-analysis you mentioned, which is at least gives us some parameters to say, okay, look, if the bladder outflow obstruction index is above this number or the bladder contractility index is below this, kind of at least helps guide us a little bit to say to the patient, well, look, actually the outcome may not be that good from surgery. So I think that that is quite useful. The other aspect with urodynamics, I think, is it does have to be individualized, and I think in any situation, I think, where the evidence is a little bit mixed or there isn't much evidence, the question then is, I suppose, what would patients want or value? And when we did one of our reviews a while ago for the panel on values and preferences, there was some research done, patient research on urodynamics. And it kind of seems that even though some people do find it embarrassing or painful, they do still prefer to have it because they believe it helps them. Patients believe the findings will help improve their outcomes or treatment choices. So I think I agree, it shouldn't be used for everyone, but I think in select cases and certain situations, definitely it's a valuable tool.
You mentioned something really important. We have always to acknowledge the patient preferences. And in recent years, a lot of demands have been raised by our patients, because now we have a plethora of new minimal invasive surgical treatment options that promise certain results. So when we talk about these new technologies that entered the field some years ago, what is your opinion on that? Do they really add something valuable to the armamentarium of LUTS treatment, or is it hype?
Actually, I think that we have some valuable techniques, but I think we should be careful, because we need to correctly assess the patient, talk with the patient about the risks and benefit of this specific kind of minimal invasive technique, but also be humble and think about the fact we have the correct expertise, the correct armamentarium in our centers, and also think about the costs. Because sometimes we cannot offer this kind of technique. For example, let's talk about Resume, because of costs, but maybe we have a good patient selected for that specific approach. So actually, I think that they have promising results. We don't have yet strong studies to support them, but if we want to use it, we should be really honest and do it if we have the right experience, the correct center in which performing this procedure can be done in expert hands with the correct armamentarium, and talk really honestly with our patients about the risk and the benefit also of a repeated procedure, because the first one is not enough the final solution.
Okay, I see. Now we have, on the one hand, medication. On the other hand, we have those classic ablation techniques. Where do you think do they fit, these new technologies? Do they substitute the established reference method, or do we need to place them somewhere else in our algorithm?
It's interesting because a lot of the trials, when people are setting up these trials for these new devices, or companies are setting up their kind of pivotal studies, sometimes they're told, oh, you should compare it against a standard of care. But what is that standard of care? Is it a comparator to TURP, for example, or is it a comparator to medications? Is it a separate group completely? Yeah. And I think that's the difficulty then when looking at some of these studies, knowing exactly where they fit. And actually, as you say, I think it's probably somewhere in between. Yeah. And it depends what the patient wants. Do they want a very effective long-term solution? Then we know the ablative techniques are likely to give that more effectively. Yeah. Or do they just not want to be on medications? They want something to give them a bit of improvement for however many short-term, 5 years or so. But I agree, the studies are, for those reasons, it's quite hard to really assess against, to know what you're comparing against. But I think they fit in a separate group.
I think they are quite in the middle. What do you think?
Exactly.
In the middle, in terms of outcomes, functional outcomes, but also in the middle in terms of side effects. So you start with medications, then you go a bit up with minimal invasive surgery, and then with ablative surgery with benefits, but also more side effects. Yeah. So I think you should balance, these two.
The interesting thing is the techniques. I completely agree with you. But the newer techniques coming out. Question is, do some of those bridge that gap a bit? So for example, I mean, there's a few different. But for example, water jet ablation, aquablation. Yep. Does that actually bridge that gap between preserving good functional outcomes, but also giving good efficacy? Yep. And there's interesting data coming out on all of these aspects. One difficulty, I guess, with these trials is the key studies are often done by very high volume centers, expert users. The question is, if you generalize that then to everyone, do we get the same results, same outcomes?
Yeah.
Exactly.
Okay. So could you think of a scenario where these new minimal invasive technologies might replace completely medication? Because as we know, medication, there's a compliance problem, efficacy is not that good, and then the longer we wait, the more damage will be done to the urinary tract. So if we go to something more efficient at an early stage of disease progression, is that something that you can think of, that these new technologies might change something in our basic management of LUTS patients?
Probably in the elderly. I think that old patients can benefit more, because you don't want to go for a more aggressive surgery because of side effects, and also because it's a real surgery. And maybe you can balance the harms and the benefits with a less invasive surgery, but also with the less side effects compared to medications. So maybe in the elderly, or in people that want to preserve the ejaculatory function, that can be useful.
Yeah. We're seeing a lot of patients now coming through, say young men, who just don't want to be on medications because of the medication side effects, especially 5-alpha reductase inhibitors, for example, effects on libido and other things. So actually more men are preferring, at least than previously, to have some kind of intervention, but minimally invasive, just to not have to be on medications. Yeah. But you mentioned a really good point, which I think is often overlooked, on secondary bladder dysfunction. So, do we operate too late, or
exactly.
People that have been using medications for years, actually, is their bladder going to be in a worse state when we operate in 10 years' time, for example?
Yeah.
I think it's a really interesting aspect of it, because at the moment we don't tend, or at least in daily practice, we don't tend to focus so much on, if someone has some mixed LUTS, we may say try the medication, but we don't really say to them, well, we could give you medication, but if we do an operation, you're more disobstructed, maybe your risk of bladder dysfunction in 15 years is going to be much better, but we don't know. But
Yeah.
so I think that's a hard area, is the secondary bladder dysfunction that happens.
Yeah.
I guess that's an unsolved question in all of the guidelines. When is the right timing to intervene, right? We have the feeling, at least in Germany, that we are waiting too long. When the intervention is taking place, too much damage has already been done, and of course then we know the outcome will not as good as a surgery done 5 or 10 years earlier. So this is something we still have to work on. Final question, what's your experience with some of these new technologies? Is there something that you personally prefer over other techniques now because it convinced yourself? Is there something that you like to share?
Actually, I don't have enough experience on my own on these techniques, and I come from a center where HOLEP and enucleation techniques in general are more used, and we are used to treat that patient in that way and to assess that patient for that kind of surgery. Yeah. So I cannot give you a definitive answer, if not what I have learned being a board member of the guidelines, because I don't have a real clinical experience on this. We are starting to perform this kind of surgeries in our center, but we are in the beginning still, and we are selected surgeon who are doing this kind of surgery because we think that focusing on that surgery makes the results better. So we are not doing all the same stuff, but all of us is focused on a determined kind of surgery.
So is there something you prefer?
No, I'm lucky enough where I'm able to kind of perform all of these procedures. And I think it does you have to select correctly, but just personal opinion, having used a few of these techniques, I think the one that really stands out to me most is aquablation. Mm-hmm. And finding that outcomes are actually good, patients are very happy, and they get to preserve most of their functional after effects, ejaculation-wise, no incontinence. Actually, I'm finding daily in my clinical practice a lot more patients are taking this up and are very happy with it.
Oh, it's interesting to hear. So, dear friends, as you can see, different guidelines, but we all think the same patterns. So in this regard, the thing that matters the most is the health of our patients. So we're still trying to offer better clinical treatment. So in this regard, on behalf of the editorial board of the UROLUTS educational platform, it was a pleasure to have this discussion with you guys. We try to keep you updated on a monthly basis. So stay tuned and still enjoy this very nice congress.